Good evening, everybody. Now, I'm going to talk to you on a subject that you probably wonder what the hell is this. This is called iatrogenesis imperfecta. Actually, I thought that I'm the one who coined this name, but later when I went through, I found that this is actually this is a known disease entity, right? And also, this I have to tell you a little bit about this lecture. This lecture I made about 20 years ago. And I first gave this lecture in Manila University, and then I gave this lecture in many universities to medical students, because they said that this is probably the most important lecture for medical students. But when I realized most of the audience here are senior registrars, and SHOs, I thought it is actually very, very desirable for you people as well as pediatricians. This is entirely pediatric related. Now, this is my first slide. Now, you know that clinical diagnosis is based on 4 pillars. Number one is that you have to take a detailed history. Detailed history within a short period, because now in the exam, for example, you are having almost 25-30 minutes. But in real life, you have only few minutes to take the history and examination. So therefore, it is very important for you, depending on the presenting complaint, what to take in the history and what not to take. So as the examination. So it's a long process that you will learn when you are dealing with patients. Right. Number two, so you have to take a detailed history, and number two, you have to examine the child properly. Then you have to take laboratory and radiological investigations, and then you have to do logical reasoning. Right. So the important thing is that the the most important thing is, so therefore it's depend on history, examination, and laboratory and radiological investigation. But the most important thing is logical reasoning. You have the having knowledge is not important. That more than that, you have to be really, you have to have what you call a logical reasoning. Right. Right. So you have to have all these 4 pillars in your diagnosis. Now, in actual practice, you don't get this textbook patients. We call them textbook description. It is not there. You find sometimes the investigations may not fit into the clinical findings, or sometimes the clinical findings are not really classical. You don't see the way that you think about, the exactly what you think about. So therefore, taking actual clinical scenario case is probably not really what you see. Now, for example, Kawasaki. I'm sure you may have seen atypical Kawasaki. They don't have the real picture of Kawasaki. So as almost every disease, you don't see them as you have learned. The second important thing in pediatric practice is it's extremely difficult. You cannot, everything is difficult in pediatrics, because that you are not getting the first-hand information, because you cannot talk to the child often. If a child is less than 2 years, you may not be able to speak to the child properly. So you are getting second-hand information. Unlike in adults, you are getting second-hand information from already anxious parents. So she will add a little bit of salt and pepper to the story. Very often you must have seen, when a child is having diarrhea, if you ask the mother, the mother will say, "Ane sir, me lammat me thank balan ko janwane vinadi paim part badili yanwane." So that will never happen. No, vinadi paim part means within 1 hour, almost 12 times. So for a day, about 240 times, that is not happening. So they are exaggerating, you say, their symptoms to get their attention. If they have mild fever also, they say very high fever. So you are getting second-hand information. Second thing is the examination. You are not in a position to examine the way you wish. They yell and they will not allow you to touch. So you are having a second problem. You can see the tragedy going through this. Trying to examine the ear, right? And also, it's very difficult to take them into to do investigations. So you see, so difficult for you to get all the information what I told you. History taking is difficult, examination is difficult, laboratory tests are difficult. So you are dealing with an interpretation. Once you do the laboratory investigations, your laboratory findings are different in different age groups, from newborns to infants, the infants to the others. So you are having lot of problems in everything. All the four pillars I told you, except your logical reasoning, everything else is difficult. And the difficult behavior of the patient. This is another thing. Sometimes the child is very difficult. Now you see, they say the pets and children have many things in common because they both hate strangers. They refuse to eat when they are very sick. They begin to play when they feel well, and always brought to the doctor by someone else. And also, the complaint is not made by the patient but by the accompanying person. And also, they don't like to disturb and get angry if you hurt. So we are like veterinary. We are more like veterinary surgeons than the real physicians. So therefore, ladies and gentlemen, pediatricians are the best detectives in the world, because you have to use very limited resources to make a diagnosis. Now, what are the problems that we are going to face because of this? Number one is we are heavily reliable. Pay heavy reliance on laboratory radiological investigations and advanced invasive and non-invasive tests. And we fail to appreciate the value of proper history taking and examination. This is more so in the modern world, because when we were medical students, we were able to diagnose a lot of diseases. Like in the exam, for example, they expect us to diagnose what is exactly wrong with the patient: mitral stenosis, mitral incompetence, or any murmur, whether it is a ASD, VSD. Nowadays, we diagnose only a cardiac murmur, and the cardiologist will diagnose what the problem is. So those days, our clinical acumen is much more than the present day. Now, this is the first case. Are there any doctors around? Why you have to answer this question? Huh? A 6-year-old boy was admitted to the casualty with a history of headache, vomiting for 2 days, and a fit. On examination, he was found to be drowsy but conscious and rational. His pulse was 88 per minute, respiratory rate was 18 per minute, BP noted as 120 by 80. And on examination, we found that he was having bilateral papilledema with retinal hemorrhages. What will you do now? Obviously, LP was not done because of papilledema. LP was not done. A CT scan was done, which was reported as normal, and hence a course of antibiotics for possible meningitis was commenced with mannitol, dexamethasone, and also fluid restriction. Right. If there are doctors, just tell me, is our the treatment is okay? Huh? Anybody? Right. The day 2, the child was slightly better, but headache persisted. Serum electrolytes were normal. Urea, creatinine were elevated, which was thought to be due to fluid restriction. And remember, every case I am going to report here are genuine cases. They are not fabricated cases. Actually, I initially had about 8 cases, but now because of the time I reduced it. Then day 3, the mother complained that the child has not passed urine since previous day afternoon. A little urine pass was dark color. Urea has gone up to 15 millimoles per liter. Electrolytes remain normal. And then we suspected HUS because they have a Urine showed moderately full red cells. HUS was suspected, but platelet count was normal but very low. So is the diagnosis right? Anybody? If there is anyone? Right. All right. So Thursday afternoon, he threw another fit. Anti-epileptic started. So now where are we? Many brains were put together to re-evaluate and ask for any clues because people did not know what the hell, because the child did not have any fever. Medical students clerking the patients were itching to make remarks. So what do you think about this patient? And then they came with this idea, sir, acute glomerulonephritis with hypertensive encephalopathy. But there is no hypertension as far as we know. So we asked how, and he said, we checked his BP today and it was 200 by 165. Now you go to the case before, the blood pressure was checked at the admission by a OPD doctor, but you know in the OPD sometimes the blood pressure was not right. And I don't know whether this happens here still, but we don't do routinely, you don't check blood pressure in children. In this case also the blood, now this is the third day I'm talking about, that is 48 hours after, still the blood pressure was not recorded in the ward. It's recorded only once or maybe twice, but it was repeated as same. But the medical students, when they checked, it was so high, and when we checked it, it was much more than this. So actually, at last we made the diagnosis. So it was actually acute glomerulonephritis with hypertensive encephalopathy. Only unfortunate scenario here is the patient present with hypertensive encephalopathy before he present with oliguria and hematuria. It may have been there, but we have ignored. The parents must have ignored. They didn't tell us, and nobody knew about it. And we were not bothered to ask about it. So this is what it is. So what are the lessons that we learned? The lesson we learned is the basic examination is essential in assessing people, children. Doesn't matter what it was. So the pulse, blood pressure has to be recorded in any child having problem. And the second thing is, common things are more common than having a HUS and all that. And this is a rare presentation because it's not the way that the glomerulonephritis and hypertensive encephalopathy present usually. So rare presentation of a common problem is commoner than a rare disease. So we miss this because that we have really failed to check the blood pressure and to take a detailed history. Right? Right. This is why I said, then I thought that this name is coined by me, but then I found that there's a chap called Moro G. He has coined this name long ago. It's about 25 years ago. In this medical age, which relies heavily on electronic and technological advances, the physician is often willing to place unwarranted confidence in laboratory data regarding his patient. In those unusual situations in which the patient is not directly examined, then you make a wrong diagnosis. But my definition is a little different. My definition of iatrogenic imperfecta is a mismanagement of a patient by a doctor due to unintentional failure to take into consideration of essential clinical clues, whether it is in the history or it is in the examination, that if you really do not get this, you don't rely on these essential clinical clues, you might make a misdiagnosis. And also mismanagement due to unnecessary reliance on laboratory or other technical investigations to make the diagnosis. A classic example is, I just saw 2 days ago a patient with a diagnosis of dengue fever. The platelet count was 350 to 52. I said, nothing, you need not to get admitted. There's nothing wrong. Then I said, don't worry about the diagnosis. You need not to do. You do the full blood platelet count for tomorrow also, and let me know. So that day also they did a count, and while they were staying that, they said the mother is having a cough and cold. I said, okay, you check the mother for COVID. I'm sure this child also having COVID. And when they checked the mother was positive for COVID, and the child also positive for COVID. So that dengue diagnosis was wrong. So if you are rely on that, luckily the mother had cough and cold. Otherwise, we would have just thought dengue fever, and we were managing this child. So this is very important. You cannot rely on the laboratory investigation. You have to use your common sense. Now the difference between iatrogenesis imperfecta and iatrogenesis neglecta. Imperfecta is that it's a error of omission. You are not doing it purposefully. But neglect is error of commission. You do not, now say for example, if you don't come to see a patient and patient dies, that is error of commission. And imperfecta is very common. We all tend to make this mistake. But neglecta is very uncommon. I don't think in Sri Lanka that doctors do that. I don't know. And imperfecta is actually misinterpretation of findings, whereas in neglecta is a lack of responsibility. Now, what are the common errors we have? Omission of relevant parts in the history, misinterpretation or omission of physical science, misinterpretation of laboratory findings, unwarranted confidence on laboratory data, jump into conclusion without evidence, reliance on previous diagnosis. This is very important. Use of wrong drugs or inappropriate dosage, lack of common sense, and very often a combination of above. Now, I'm sorry about this. Because in my computer, of course, you can see this nicely. A 4-month-old baby was brought to the eye department by the mother for some whitish mass seen inside the pupil in both eyes. So the mother brought this child, but she had seen something white in the pupils. She also said that she had 2 other children with the same problem and died very early in life. And a maternal uncle also, mother said, he had the same problem. So the immediate conclusion of the person who had seen was a familial retinoblastoma. Other 2 kids also had retinoblastoma. There's one uncle also having retinoblastoma. So the diagnosis was retinoblastoma, which is familial. So immediate conclusion was retinoblastoma. MRI scan showed a mass localized to the eye ball, not extending beyond retina. As the tumor is localized, immediate enucleation was done in one eye with intention to remove the other eye later. All done in good faith to save the life of this child. Make a problem. Make one after the other. Anyway, it's okay. Now we'll carry on. So in this particular case, the diagnosis was made. One eye is removed. The eye which is affected most was being removed, because otherwise he will die of this retinoblastoma. So this is the X-ray of this patient, and the biopsy report confirmed that the tumor was not a retinoblastoma. Now what? You have already removed one eye. These are all true stories. And in fact, this particular eye, the surgery was done in Singapore in this particular patient. Now see what we have missed. In this case scenario, all the affected people are males. 2 other children in the past and the mother's brother. So this is all the affected people are males. Now you get the clue. So this is a sex-linked disease. Both those children with the problem, if you ask very carefully, true that they had the problem, but they actually had died from some other reasons. One child died of severe gastroenteritis, the other child died of some different cause. So none of these kids, the other 2 kids, died of retinoblastoma. True that they had it, but the history has not been taken properly. Those 2 kids died of something else. And also, The maternal uncle is still living without any surgery. So how can that be retinoblastoma? Retinoblastoma is a malignant disease. He wouldn't have survived. So now we have to think of something. And also, all the affected people are deaf. So we are dealing with some other problem. So that alternative diagnosis had to be considered in view of those findings, which has not been taken into account. Probably not, never asked. Because you jump to a conclusion of retinoblastoma by seeing the CT scan. And this is the MRI, just to show you, this is called Norris disease. And just to show you that Norris and this is the same. There's not much of a difference. Only difference is that in a retinoblastoma, when it becomes invasive, you can see the lesion goes everywhere. But here it is restricted all the time within the eyeball. It never goes out because it's not it's a benign condition. It is called actually hyperplasia of the vitreous. So then they have unnecessarily removed the eye of this patient. Norris is a sex-linked disease with persistent hyperplasia of primary vitreous and microphthalmia associated with deafness. It is often misdiagnosed as retinoblastoma unless carefully evaluated. So what is the lesson? The lesson is a detailed history would have been sufficient to make the right diagnosis. If you have taken the detailed history in this particular case, you would know exactly that this child was having Norris and this child did not have retinoblastoma. That eye need not to be removed. Even though the child probably does not have the proper vision, but still the child will have both eyes. See how tragic we are. These are called actual iatrogenesis imperfecta. Now this is the second case. A 4-year-old child was brought to the pediatric clinic with bow legs. They have another boy with the same problem. This happened actually at LRH. Another boy with the same problem who is 6 years old and had been already diagnosed as having familial sex-linked vitamin D resistant rickets in another teaching hospital. So the child came with a diagnosis card from the other child. Right? X-ray wrist was reported as having classical changes of rickets. Serum calcium, serum phosphorus, and alkaline phosphatase were normal. So we have 2 boys resistant to therapy. Diagnosis was made despite the normal biochemistry. Serum calcium is normal, serum phosphorus is normal, serum alkaline phosphatase is repeatedly normal. So diagnosis was made without having normal biochemistry. This time on clinical and radiological findings and based on the diagnosis of the other child. So you diagnose this child having the same problem because you have taken into account the clinical features, the radiological findings, and the diagnosis of the previous child. So this is the X-ray. These are pretty old X-rays, so that is why they are not very clear. The treatment with 1-alpha did not show any improvement and the dose was repeatedly stepped up in visit to the clinic. So each time they went on increasing the because child is not improving. No attempts were made to find second diagnosis. We know that vitamin D, although we were told that vitamin D can excess can cause toxicity, now they know it is very rare. But these kids have lethargy, anorexia, and loss of weight. That is because we were giving loading doses of 1-alpha with no improvement. Though both children were boys, so that is why they were thinking of sex-linked disease. There was a history of consanguinity, which they have not asked. Now you have to think of autosomal recessive disease, normal biochemical findings, and poor response to vitamin D. So could this be something else? Of course, yes. This child had metaphyseal chondrodysplasia, which has nothing to do with vitamin D. So child was given loads of this. Then what are the reason lessons here again? Never rely on the previous diagnosis. You should never rely on previous diagnosis. It may be a very hi-fi posh boss or the the authority, but still maybe you are not probably a consultant, but you have to trust yourself. Is the diagnosis right? Never mind who the boss is, who made the diagnosis. Number two is do not jump to conclusions without evidence. Here they jump to conclusion without evidence. Now this is a very interesting child. This is a chest X-ray of a 4-month-old child who presented with cough and runny nose. There were no clinical signs of auscultation. He was given IV antibiotics for 7 days for apical pneumonia. Child is only 4 months old. So whenever they get aspirated, they get the apical pneumonia. So he was treated for apical pneumonia. Now, you see carefully, this child never had fever. There were no physical signs when you examine, and he had only X-ray finding. Should that child need antibiotics? Just because the child is having runny nose and a cough and probably mild infection. Now, this is the X-ray, original X-ray, which is rotated. You can see it's closely rotated. And when you correct the rotation, you can see this is just a little bit of thymus. So here you are treating the thymus, not the apical pneumonia. Right? So these are all lessons for you people, young doctors. You do not rely on those things. You think twice. Use your common sense. A child here we have a child having cough and cold, but no fever, well-looking child, not dyspneic, no physical signs, no grips, and just you are treating the X-ray. So the lesson is never treat the X-ray report, treat the child. And trust your own findings. If you can't find anything, don't treat. Never mind the X-ray. This other case, a 6-year-old Nepali boy. This happened actually when I was in Brunei. We have a lot of Nepalis there. A 6-year-old male Nepali boy was investigated for headache and some weakness of right hand. His reflexes were noted as normal, and no muscle weakness was found. A CT scan was done, which is reported as having a calcified lesion in the left cerebellum, suggestive of tuberculoma. Subsequent questioning revealed contact history of tuberculosis, and the MAN2 was done, which was in duration with 9 to 10, it was very high. Chest X-ray reported normal, but because of this MAN2 and because of this, there is a contact history, and you have treated. Now, a word about Nepal is coming to Brunei. Most of the Nepalis, when they come with a diagnosis of TB. I think they are overdiagnosis in Nepal. Every child with cough for more than 2 months, they think it is TB. And the X-rays also I have seen, a normal X-ray they report as TB. So this is happening in Philippines as well. I have seen many times the Filipino coming with reports TB, but they never had TB. So this is overdiagnosis. So this contact history also may not be right. Right, the MAN2 may be high anyway in the Nepali children. So course of anti-TB treatment was given, headache disappeared, but this complaint of right hand weakness persisted. But when he was seen after 9 months, we saw this child was having cerebellar signs coming up now. So we did MRI. Now this is the original CT. You can see that there is a calcified mass here. So when we did the MRI later, you can see a child is having the lesion in the cerebellum. You can see, and it is actually, you can see that is infiltrating, and also you can see it involves the brain stem as well. So this child is having an infiltrative disease. MRI findings of this sounds 9 months later, the diagnosis came with grade 2 invasive astrocytoma. And this is the lateral view. You can see it's affected everywhere, including the spinal, lower part of the spinal cord. Once the whole thing has gone completely. So we missed this initial calcified lesion as tuberculoma. So again, do not jump to conclusion without thinking alternatives. So if we had done, I don't know, if we had picked this child up in the beginning at 9 months ago, things would have been different. Perhaps. We never know. So this is the last part of my talk, because I'm sure that you are probably not sleepy like this. You are probably hungry. I can see people are yawning because you may be hungry. But now I am going to tell you 7 golden rules to follow to prevent this iatrogenesis imperfecta. Number 1 is mothers are always right until proven otherwise. I will tell you a very anecdotal story. While I was doing a ward round when I was in Chilau, there was a child who was having fever, and we examined the child. We could not find anything. He had fever, true, but he was and some vomiting. A small child, about 2 years. Everything was fine. But each time when I do the ward round, the mother comes and tells me, "Sir, this is not my child. My child is very active. He is playing. He is not like this." Then I asked, I said, "Yes, sometimes when the children get this, no, 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 I am sure there's something wrong with my child. Sir, mole unadu danne naha." Then I told my house officer, "Amma kippayitha apita atharina berlaga mole unati unuttama, you do the lumbar puncture." Actually, then I examined and the fundamentals were normal. There was nothing very much, but we did a lumbar puncture. So I thought that probably there's next sickness. That also I checked before after the mother told me. When we did the lumbar puncture, it was pure bacterial meningitis. So I mean, this is a bit of exaggeration, but this is truly what has happened. So remember, the mother knows their child well. So if they say that there is something wrong, you don't take it very light. It's all his mother is always right. I have seen many a times the doctor say, "Pisuda amme kisile danne arai yanna bayan deyak naha," which is very wrong. Mothers are always right until proven otherwise. Remember this. This is one golden rule for all the junior doctors. Second one, you have to be very open-minded. Always think of other possibilities. It doesn't matter. You make a diagnosis today. When you are doing the ward round tomorrow, you can make a second diagnosis. There's nothing wrong in that. It does not mean you are an idiot. It means you are a very clever doctor. So think of other possibilities all the time, constantly. Never believe the previous diagnosis. Remember, your boss is not always right. Just because the boss said that, just because the most eminent neurologist told you, don't believe that. I have a classic story which I purposefully did not put this. It's a very interesting story, but if I have time, I'll tell you. And now the other important thing is, I have seen very often when they come with a diagnosis, there are 2-in-1 diagnosis card: typhoid fever and gastroenteritis. So if you have 2 diagnoses, very often probably it is one diagnosis with those 2 problems. So try to fit into some illness. I'm sure then you will be able to make that. So don't try to make 3-in-1, 2-in-1 diagnosis. And also the most basic concept is common things are common and rare things are rare. And this is common sense, and use it all the time. So don't come with rare diagnosis. When I can remember, when I was doing my internship at LRH, I happened to go with my boss for exam. So the medical junior medical, they are medical students. So there was a child who had post-measles stain. We gave the case to the medical student, and he was asked, "What is your diagnosis?" This I can still remember, almost 50 years ago. The medical student said, "This is letter-heavy disease." My boss said, "What the hell is that? I don't know. What is letter-heavy?" So you see, so this is the problem. You have to think of common things first before you think of rare diseases. So then my boss started shouting at Priyani, because the boss I worked with a very senior pediatrician. So she shouted at Priyani, "What the hell you people are teaching these fellows?" But this is just to let you know that common things are common, rare things are rare. The other most important thing is trust your ability more than anything else. No laboratory, don't respect laboratory tests, don't X-ray reports, don't respect other people's diagnosis. You respect your own judgment. This is always I tell all my students, all along my life, this is what you ought to do. Trust your own ability. And another important thing is do not invent clinical science. When you are examining something and you see that, oh my God, yeah, this must be the reason, then you invent other physical science. So never invent physical science. If that is not there, it is not there. Think of alternative. Finally, this is Leonardo da Vinci said that you have to learn to see things. You have to learn to see things. If you really look properly, you will see. I will finish my story, but I will tell you the other two stories at the end. I'll finish my talk now. This is actually the story of Arjuna. I'm sure those there are any Tamil doctor, they know who is Arjuna is. Arjuna apparently has a master called Dronacharya, and Dronacharya, he had taken his people to a jungle and showed a tree, and and asked them, "Do you tell us what you see?" So some people said there is a tree, and there are two birds. Some people say it's a tree, and when they asked Arjuna, he said that I can see a tamarind tree and two parrots in it. So then he said, the teacher said, Arjuna, you are the right person. You know how to see things. So this is what is very important, because you have to see things. But if you don't see, you miss it. Now, for example, I'll tell you one thing. When I was working at Javardhanapura, I used to teach all these children about patients about because my fascination for neurology at that time. So I taught every neurology used to read everybody's EEGs and all that. And that particular time that there was a patient who came with a murmur. We could not really work out this murmur is coming and going, and we were a bit fussy. So we sent to, at that time there were no cardiologists in LRH, so we sent to General Hospital. And my house officer happened to go there for for 2-3 months. Not my house, my SHO for cardiology, and he was there. When they examined the patient, they found the child was having a atrial myxoma. True story. Then my house officer said, sir, my boss used to tell me if there's atrial myxoma, you should look for tuberous sclerosis. Then the cardiologist said that, okay, you look for tuberous sclerosis, and they found tuberous sclerosis. He was having on the back, he was having capillary patches, he was having hypomelodic patches, and he had a sharp green patch as well. So when the cardiologist wrote to me back about the patient, he said, this child is having atrial myxoma, and your student, your SHO has made the diagnosis of tuberous sclerosis because you have told him that it is tuberous sclerosis. So I missed it, because not only we missed in the ward. So this is because we fail to see things properly. I am telling you, this can happen to anybody. Right now, so thank you very much. I have finished my talk, but I thought that at the end, I have to tell you two important stories. That this is a very interesting story. When I worked in Javadhanapura, this particular patient came with a diagnosis of hypogammaglobulinemia, diagnosed in Russia, because this couple went to Russia for their education. Russian university. There they delivered this baby, and there the child had 2 attacks of cough and cold and diarrhea or something. When they investigated, they found the child was having low immunoglobulins, both IgM, all IgM, IgA, and IgG. And then he was given every monthly immunoglobulins. So they came to Sri Lanka. They went to Professor Stellardi Silva at that time. She was in the private sector at that time. So she went to Stella. Stella had seen Stella, and then Professor Stella De Silva referred the patient to me. I was at Jawaharlal. HT looked into this patient. So when I saw the patient, I saw this diagnosis card with hypoglycemia. When I look at the child, I thought the child is perfectly well child. And the history is the child had never had any problem after that. And the parents insist that it is because the child is getting immunoglobulin, and the child, they wanted to get immunoglobulins. At that time, we had immunoglobulins IV, but they were extremely expensive, and we could not afford to give that. So we were planning to give this IgM, immunoglobulins IgM, I intramuscular. This is not going to work. So I explained to him, I said, I will look, wait and see, because I am not happy with your reports from Russia. But they said, no, 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 Russia, they are great people. They know how exactly wrong, and you are wrong. They are having no problem about it. So they went back to Navaloko somewhere where they have given that. But anyway, eventually I saw the patient again. I explained to the parents. I went through all the literature. I will show you just briefly some of these figures. Now, see, this child is 4-month-old baby. You can see if you take IgG, for example, it's 637, and this is the adult level. So when you compare with the adults, it's much less. Same with the IgM, and same with IgA. So all these things are, because as you grow, when you get more and more infections, you get IgM is going to build up, IgG is going to build up. So he is a 4-month-old baby. Obviously, they don't have that much of immunoglobulins. So this child never had hypogammaglobulinemia. It took a long time for me to convince the parents because of the wrong diagnosis, and people went on believing that diagnosis. Now, my final thing, I just tell with the story that I had. I will not quote names because that is why I took that out, but I think it's very important. I had a patient who were in Colombo. I was in Chilava at that time. This patient was managed in Colombo. And the diagnosis was actually diabetes mellitus in a family of 2 children. Both are having diabetes mellitus. And the pediatrician was so nice. He has informed the put in the papers, and some donor had given a fridge and to keep the insulin because they don't have fridge. They are from a village in Chilao. So a fridge had been given by them, and then eventually they were keeping the insulin in the fridge, and this child is getting insulin every day, both these kids, and then referred for me to follow up. Actually, it's been referred to the previous pediatrician, one who was before me, and he was following up, and then I went there. So I started following this patient. And when I was trying to question them, these people, they said that these kids are getting fits in the night. They are giving BD insulin, and they are getting fits in the night. So hypoglycemic, I said, in that case, you need to be admitted to reevaluate. So I admitted them, and then I found that their insulin were perfectly okay, obviously, because they are getting insulin. So I stopped insulin. And I find they don't have hypoglycemia. When you check the urine, they are having glucose in the urine, but no diabetes. So obviously they are getting severe hypoglycemia in the night because you are giving the night dose of insulin. And unfortunate thing was that when they went to the LRH again, that hospital, they started shouting at the mother. And then in the morning, what they do is, when they check the urine sugar is plus, so they go on increasing the dose. They increase the dose because urine sugar is there, but the child is getting fits. The more insulin you give, they are getting fits in the night. So I stopped all the medication. I said, all right, you come after if the child is having a problem. So then the child both these kids started to gain weight nicely. They have no problems whatsoever. And then they were perfectly okay. So then Because the child was not going to the clinic in LRH, then the LRH people had written to them saying that why you are not coming. So this stupid father had written a letter to the consultant in LRH saying that මේ අපිට දෙයිනේ කියලා මේ දෙවි කෙනෙක් වගේ ડોක්ටර් කෙනෙක් හම්බුණා. එයා බේත් නවත්තපුවා. දැන් අපේ ළමයා හොඳට ඉන්නවා. අපිට හොයන්න උවමනාවක් නැහැ. So obviously, naturally, the pediatrician got really wild because he had gone to such an extent to put in the papers and given a fridge also. So she got really annoyed. She said, "You okay? You send the fridge back to us." Then he said, "Okay, I will do that. I don't want the fridge anymore." So anyway, to make the story short, then the pediatrician gave me a call. So I said that, this is what has happened. Actually, they are having isolated renal glycosuria. There is no diabetes. And all these things are not right. And I stopped it. So I sent them. I persuaded the parents to go back there. And they went back. And then they have taken the diagnosis card and removed the diagnosis card and given a new diagnosis card. But the story is that pediatricians are so nice, they have asked them to keep the fridge. That is kerosene fridge. I'm sorry about it. I forgot to mention because they don't have power, electricity. So it's a kerosene fridge. So that was the story. The story tells you that the wrong diagnosis was made. Just because you are having renal glycosuria, that does not mean you are having diabetes. And you need not to start treatment just because the child is having persistent glycosuria. You have to make sure that the child is having diabetes. Right. Thank you very much. I hope that you learned something.